I think next talk is by Dr. Sujata. Antiviral drugs, I think.
I thank Dr. Parul for inviting me for this talk. So before I start with this talk, so whosoever PGs are present here, what viral conditions you have seen frequently in your OPD? Just I will take 1 minute. Who has seen viral keratitis? You can raise your hands. 1. Okay, which condition you have seen? In herpes, what condition further? Okay. Anybody else? Yes. Which condition you have? Okay, you have seen. And okay. And rest have never seen viral keratitis. Okay. So it will be a bit difficult because unless we have seen anything, we can't relate to it. Anyway, I will try my best. So today we will be dealing only with HSV and VZV. In that too, we will be restricting ourselves to these drugs because this is a very vast topic. We will be just touching hardly the tip of the iceberg. And again, we will be discussing only the topical and oral route. And I would like to tell you what is the difference between therapeutic dose and prophylactic dose. Since you have not seen the diseases, so it may be a bit difficult. Okay, let's start with the basic. Both these viruses, herpes zoster and simplex, they belong to the same family and subfamily, only their genus is different. Because of the similarity between these two, they have a common morphology, the way they replicate inside the body, and the cause the recurrent or latent infection is quite similar. And this is the reason that almost same drugs work for them. Most common drug which we use is acyclovir. Okay, and we know whenever virus is replicating, it is synthesizing its DNA. And if we stop that DNA replication, we can stop the viral replication. So acyclovir is an analog of guanosine. Beauty of this drug is that this drug needs to be activated first. And that activation specifically happens inside those cells which are infected by virus. So that's why this drug is very selective. It does not damage the rest of the cells. And that's why adverse effects are minimal. With the topical, whatever adverse reactions we see, they are mainly because of the vehicle of the ointment rather than the drug. And similarly, the oral drug is very well tolerated. Only few people get the GI disturbance. One problem regarding this drug is that it is excreted by kidneys. So if the patient is having renal failure, you are giving oral dose, that dose needs to be reduced. For the topical, whenever patient brings to you the ointment, please check it because chemists sometimes don't differentiate between 3% used for eye and 5% used for skin. And ganciclovir comes only in 1%. In oral, we have the different dosages which are available. Good thing about acyclovir is that it is a prodrug of acyclovir, but its bioavailability is very high. With the acivir, hardly 30% of the drug gets absorbed. With the acyclovir, absorption is high. This is the reason that the dose which is required for acivir is higher, for valcivir it's less. So if the acivir patient needs to take 5 times a day, means every 3 hours, whereas valcivir is required thrice a day. So the dosage is much more convenient. And the same conversion goes for the higher dosage. Only thing is money. If you see the difference, how much a 400 milligram 5 times a day will cost to patient versus how much acyclovir cost, the difference is more than 3 times. So whenever you are mentioning acyclovir or acyclovir, please consider patient's economical condition. Secondly, whenever people have tested in viral cultures, the dose which is required to kill the virus is much more higher for zoster virus than simplex virus. So that's why the dose is different. Let's start with this simple condition. You must have seen these patients. Herpes zoster. Now, in herpes zoster, virus is actively replicating. We need a dose to kill the virus. I have just shown you that the dose which is required for VZV is double that of simplex. So 800 milligrams 5 times a day. The drug is most effective within first 3 days. After that, the drug is not that much effective. Some dermatologists give even within 7 days, because in some patients few vesicles still form after 3 days, and after 7 days if patient is coming to you, there is no point in giving the drug, because now the virus is not actively replicating. And the second condition, which I think two people of you have seen, is dendritic ulcer. This we see in herpes simplex virus. Pathology here is also same. Virus is actively replicating. But the good thing is that unlike in herpes zoster, where we require oral dose, here we have topical. So we have Acivir ointment available to us. The dose is 5 times a day in the first week. After that, you can taper it to 3 times a day. So the oral is required in only few circumstances, just like if the ocular surface is very bad, in those patients you give. Similarly, in a HIV patient, or the patient is one-eyed, poor vision, and ointment is causing further blurring, in those patients you can give oral. Or non-availability of the topical Acivir. Where the topical Acivir is not available, any one of you knows where it is not available? It's not available in USA. That's why those people always used to give oral. And what was available in USA? That is available now, Ganciclovir. Until now, which drug was available? But what is frequently used rather than idoxuridine is the trifluridine. So that's why all the heads trials, they use the trifluridine. So that's why in USA people used to give oral, and all the literature which we got was mostly with oral. Here again, topical is very much economical too. So it suits our country too. But here also, as I told you, that sometimes we need to give oral. For example, like this patient, she was a young female, but she was a known case of dry eye, and she was known to have viral keratitis also. For this, she received steroids, but it was not given under any prophylactic antiviral cover. What is prophylactic antiviral cover? I will discuss shortly. So she was given steroids, no antiviral, and she developed a huge geographical ulcer. This ulcer was huge. For this, she was started on Virson gel, but despite using it, the ulcer was not reducing. So in this patient, where the ulcer is very big, patient is having dry eye, that's why we opted for oral drug. So within 6 days of oral drug, the ulcer reduced by almost 2/3 of the size. This is the picture after 18 days. And what is this picture? Is this a dendrite? Simply because you have not seen dendrite, so I will tell you that the difference between these two is, one is dendrite. Dendrite is true ulcer, which goes through the basement membrane. You put fluorescent, you will be able to see this pattern that wherever epithelium is missing. The second picture is called dendritic epitheliopathy. This typically develops in certain eyes who have a neurotrophic element, so that the new epithelium which has come after healing of dendrite, this epithelium is raised, heaped up. Only problem is that it looks like dendrite, but when you stain, it won't stain just the way dendrite stains. So this means that the patient does not require any more topical antivirals. Patient requires only lubricants. So whenever you are in dilemma, please stain. And then coming to the aspect of prophylactic antiviral. What we have discussed till now was the therapeutic dose of antiviral, means the dose which is required to kill the virus. But there are certain stages when there is no viral replication. This happens many times in herpes simplex. Once in next 2 to 3 years of post-graduation, you will see there will be many scenarios when the virus is not actively replicating, but the virus leaves some of its antigens somewhere, and those antigens cause inflammation. To curb that inflammation, we give steroids to the patient. And whenever we give steroids to the patient, then there is likelihood that the active virus replication will start. So in that stage, we need to give prophylactic antiviral. So there are two conditions when we give prophylactic. First, during steroid use, and second is to prevent recurrence. So in next 3-4 slides, we will go through these two concepts. Steroid use, I have told that there is no active viral replication, but steroids are required. So these are the two common conditions. One is disciform and other is immune stromal keratitis. In the first, in the endothelium, and in the second condition, in the stroma, there is viral antigen-antibody complement reaction is happening, which is causing inflammation. To cut down this inflammation, we need steroids, and for that steroid, we need a prophylactic antiviral dose. And that dose for oral is 400 milligram BD. When it comes to topical, what should be the dose? Unfortunately, there are no guidelines. Some people use full dose, some people use half the dose, some people use drop for drop. What is this? It will be clear if you just go through herpetic eye disease study. What they did, they started the patient on prednisolone 8 times a day, and till the time prednisolone was 4 times a day, they gave trifluridine 4 times a day. Actual therapeutic dose of trifluridine is 9 times, but they gave only 4 times a day. And that dose was further reduced once the prednisolone came to twice a day. So going by the same argument, in my patients, if I have to give prophylactic antiviral, I give acivir. Full dose is 5 times a day. I give half the dose 3 times a day, and as the dose decreases, I further decrease the dose. And again, because patient has to use the drug for 3 to 4 months, it's quite economical for patient. The second condition in which we are giving long-term oral antiviral is when there is a recurrence. Recurrence happens specifically in stromal keratitis. And stromal keratitis is the disease which is the blinding disease. And people have seen that if we give oral acivir 400 milligram twice a day for long time, it has the chances of reducing the recurrence of stromal. So from 14% in the acyclovir group versus 28% if acyclovir is not given. So this is the role of long-term prophylactic antiviral. So with this, I finish my talk. I hope that you understood the difference between therapeutic and prophylactic. Okay. In herpes, we have to first of all split whether we are talking about epithelial disease, stromal disease, endothelial disease, uveitis. Okay. So out of these, if we see if there is a diffuse endothelitis or linear endothelitis, these are, in diffuse endothelitis, I give oral because the disease is there. Other than that, oral I have not given. I have given only in these scenarios. You are talking about oral steroids? Yeah, that is a diffuse endothelitis. And rest of the conditions I have not given.
If the patient has skin lesions also in case of herpes, and,
Okay.
and the patient is also having ocular involvement, so is there any role of topical ointment in case of in this case?
Again, it's gray area. Some people give, but I don't give. If the patient of herpes zoster is receiving the oral dose, then I don't give topical to the patient. But
I am talking about acyclovir in this case. Topical acyclovir.
yeah, in zoster, you are talking about herpes zoster.
Yes, ma'am.
Yes, that the patient is coming to you with herpes zoster. There are skin lesions and there are few microdendrites on the cornea. This is your. So the dose which we are giving for oral is enough. The dose is reaching inside the eye also. That's why I don't give. But as you told that in literature, we find that somewhere some people give it. But there are not absolute indications or contraindications of giving topical. But my personal choice is I don't give topical antiviral in a herpes zoster patient.